Hi, good afternoon. My name is Megan Goddard. I'm the nurse practitioner here at Cahuilla Delta for orthopedic surgery and orthopedic co-management. We're here today to talk about knee and hip replacements with Dr. Mihalcin and Dr. Kim. Dr. Mihalcin is a graduate of Philadelphia College of Osteopathic Medicine. He completed his residency in 2011 outside of Philadelphia and then served in the United States Navy as an orthopedic surgeon for 4 years. He joined us here in Visalia with his wife and 4 children in 2015 and has since been working at Visalia Medical Clinic as a general orthopedic surgeon, practicing with hip, knee replacements, fracture care, and basic hand surgery. Dr. Jun Kim recently joined us after finishing a fellowship at Wake Forest in knee and hip replacements. He graduated from Western University of Health Sciences and has since been practicing with us. Today we're going to do about a 12 to 15 minute presentation with Dr. Mihalcin regarding knee and hip replacements, and then we'll have about 15 minutes worth of questions. If now or at any point during the presentation you have a question, you can go ahead and ask online, or if afterwards you have more questions, we have a number you can call, 624-3804, and we can set you up with someone to answer those questions if anything is lingering after the presentation. You can also chat with us during Facebook Live and Instagram Live with questions. We're going to be monitoring them. If you have any questions regarding COVID-19, go ahead and send them through, and we'll try to answer them with breaks in between orthopedic questions or at the very end of the seminar. I'm going to pass it over to Dr. Mihalcin for our presentation. Thank you.
All right. Thank you, Megan. Thank you, Dr. Kim. Appreciate everybody joining us online today. We're going to get started. What slide are you on? Keep going. Go to the next one. Okay. So here you see we have a number of orthopedic surgeons in the town are capable of providing a complete spectrum of orthopedic care, ranging from spine conditions to hip and knee issues such as arthritis or even ligamentous or meniscal injuries, hand fractures or hand disorders like carpal tunnels and trigger fingers. So we really do have a wide variety of options available to patients here locally for a complete spectrum of orthopedic care, which is very nice, so people can stay locally and don't have to leave the area. So Megan gave you a brief introduction about me before we got started. My office is at Visalia Medical Clinic, and I've been there for 5 years now. I've had a great time raising my family so far in Visalia, and I really enjoy working in this area. So arthritis is a very common condition. There are many types of arthritis. However, osteoarthritis is by far the most common. It affects roughly 43 million Americans, and every year the incidence of arthritic problems in both the knees and hips is increasing, based in large part on the aging of the population. Osteoarthritis in general is wear and tear. It is a multifactorial etiology to it, meaning that there are a lot of things that contribute to who will and who will not get arthritis. The most common is genetics. Genetically speaking, if it runs in the family, odds are you're probably going to get it. How much you weigh has a large part to do with it. Any prior injuries, what type of work you do, how much you're on your feet. All of these things kind of factor into development of arthritis of the joint, especially with the hip or the knee. Any prior injuries in the past, either sports injuries or traumatic events, fractures, can also contribute to it. But for the most part today, we'll be referring to osteoarthritis when we just say arthritis. It causes pain, which is very frustrating to a lot of patients. One of the main frustrations, however, is that pain results in a change in their ability to function. So if they can't walk as far as they'd like to, if they can't do the activities that they once could, they lose some of their independence, and patients have subsequent reduction in their overall quality of life, which is very frustrating. So first we'll look at the hip. On this x-ray you can see that you have a normal hip x-ray on the left, and on the right an arthritic hip. Things we look for on x-ray to diagnose arthritis involve several things. One is the loss of the normal joint space. If you look at the hip joint on the left, it appears as though there is a space between the ball and socket in that joint. There isn't actually a space there. The ends of the bones are covered with cartilage, which is invisible on an x-ray, so that's why it looks like those bones aren't touching at that area. That protective covering, or the cartilage, gradually wears down with time, similar to the treads on your tires, and as a result on the x-ray you see a narrowing of the joint space. Other things that we look for on an x-ray to diagnose arthritis are osteophytes, which are bone spurs that form often at the periphery of the joint. A hardening of the bone, so it appears more white just under the joint surface because the joint is reacting to abnormal forces placed across it, and it becomes more dense in that area. Also, sometimes you can see cyst formation on the x-rays as well. These are all the signs that we look for on the x-rays to help us with diagnosing arthritis. Oftentimes, the degree of arthritis on the x-ray does not correlate with patient's pain. So you can have patients who have mild arthritic change on an x-ray who have severe pain. You can also have patients who have severe arthritis, such as that x-ray on the right, that really don't have a lot of pain. So we often have to counsel patients that we don't treat just the x-ray, we treat the person. So we have to make sure that things are appropriate and kind of correlate with what we find on the imaging studies, on the physical exam, and matches with the patient's complaints before we direct the appropriate care. There are many treatment options available for arthritis of both the hip and knee and other joints, ranging from non-surgical to surgical. There is not a cure for arthritis, so we don't have a medication or an injection that's going to reverse the hands of time. I use the analogy of the treads on the tire. As they wear down, we can't put treads back on the tires, so we just replace the tire when necessary. But we can certainly manage the symptoms of arthritis with various options so that it is less painful and you're able to maintain your function as long as possible. The first is maintaining a healthy diet and weight. When we walk, we put at least 5 times our body weight amount of force through the knee with each step. So by maintaining an ideal body weight, that helps with reducing the forces across the joint, or even if you lose 10 pounds, that's like taking 50 pounds of force off of the knee. So healthy exercises for people who do have pain in the joints, especially in the lower extremity, low impact is the best. So ideally, if you have access to water, swimming, or getting in a pool, and even walking in chest-high water will give you good exercise, even as compared to walking on land, due to the resistance of the water and by offloading the joints from the impact forces and gravity by being in the water. Otherwise, if you don't have access to water, a stationary bike or an elliptical machine are also low-impact activities that are oftentimes recommended. Medications can be used to manage the symptoms of arthritis. Most commonly, we use anti-inflammatory medications. These are medications such as ibuprofen, Aleve, Celebrex. They reduce inflammation, and by doing so can help reduce pain. Another option is Tylenol. Use of Tylenol is a pain medication. It is not an anti-inflammatory. However, you can use both ibuprofen and Tylenol simultaneously, and they seem to have a bit of a synergistic effect, so they work together to provide an even greater benefit than either one individually. Injections are also an option. There are multiple types of injections out there that are available, ranging from cortisone to lubricating type of injections to some of the newer orthobiologic injections. Typically, we would attempt a cortisone injection first because they're relatively inexpensive and easily available. Some of the other injections we'll discuss in subsequent slides, and they have their pros and cons as well. Physical therapy is often recommended, especially if there's any decline in range of motion of the joint as time has gone on. And by maintaining the strength of the muscles around the joint, you can maintain your mobility and your function. Surgical options for arthritis. Arthroscopy. This is a relatively minor surgery where we insert a camera and instruments through very small portals. It is the best type of surgery for things that are not arthritis. Surprisingly, you would think that people say they go in for the cleanup procedure on the knee, but an arthroscopic procedure for arthritis alone typically does not have good long-term results. It's usually best for things like meniscus tears or ligamentous injuries. And finally, joint replacement. Joint replacement, both of the knee and hip, is a very successful surgery. The vast majority of people have significant improvement of their function and decline in pain. So some of the non-operative treatments we'll talk about first is cortisone injection. It's a steroid injection. Oftentimes it's mixed with some local anesthetic to provide some more immediate pain relief. We give these in the office quite frequently. The response that people get is variable. So when people ask, how long will it last and what can I expect? It's a little bit different for each person. Sometimes if you take Tylenol for a headache and I take Tylenol for a headache, yours goes away, mine doesn't. I'd say on average, people get it at least 6 weeks, but the disadvantage is you can't give them all the time. We try to space them out by 3 or 4 months ideally, because if you inject too much cortisone in too short of a time, you can have some deleterious effects. There are some other injections which are available. The one on the left is lubricating oils, basically. They're called viscosupplementation. The first one that came out was called Synvisc, and that was made from the rooster's comb. There are multiple types of those injections available now, not all of which are made from the rooster's comb. They work for a small percentage of people. I tell my patients that approximately 50 to 60% of patients are going to get a good response to it. However, only about 20% of that subgroup is going to get a long-term improvement, such as 6 months of benefit. So when you look at it in the overall numbers, it's not a highly successful injection. A lot of insurance companies at this point have started to not cover them. Other options that are rather new, platelet-rich plasma. What this involves is harvesting a tube of blood from your vessels, and we place that into a centrifuge, which spins it at a high rate of speed, and it separates out the cells of your blood based on how much they weigh. We then harvest out the area that has the platelets and inject that into the joint or the local area, and they release chemicals that attract healing factors to that area. This is still relatively experimental. There's no conclusive data showing absolute benefit to this. What limited data we do have is that it's a little bit better for people with mild arthritis. So if you have bone-on-bone arthritis, this probably is not going to be successful for you. And then lastly, stem cells. This is the thing that we're all hoping for at some point, is that we are able to harvest stem cells and inject them into the joint, and it will somehow regrow cartilage or put the treads back on the tires. We're not there yet. Similar to the platelet-rich plasma, there's a lot of variability in the results that have been shown in the research and nothing conclusive. Therefore, it's still not something that I can say, yes, it's definitely going to work. But these are still other options besides cortisone and the lubricating injections. Next slide. Get the next slide. No.
It's on the.
Is it working? Okay. So the main question that a lot of people have is, when is it time to consider replacing the joint? I think a realistic answer to that is when your pain is to the point where it's limiting your ability to function at your desired level. I often use the analogy, if you can't make it through the grocery store because your knee hurts too bad, you're probably ready for a knee replacement. If you can still walk 2 or 3 miles and it's a little sore afterwards, so you need some Tylenol or ibuprofen, I probably wouldn't suggest doing a joint replacement at that point. So there are a couple things that we look at when patients are interested in proceeding with joint replacements. I mean, it is a bigger surgery, so the ideal candidate is somebody who has evidence of arthritic change on x-rays and has already tried some of these non-operative treatments and has failed. So if medications and injections are no longer working for you and your pain is getting worse, I think that is a reasonable time to consider doing a joint replacement. You also have to be healthy enough to undergo a surgery. So we do have you see your primary care physician, sometimes even a cardiologist, just to make sure we can assess your surgical risk. Things that also contribute to that are your overall comorbidities, your health conditions, or if you have heart disease, if you have high blood pressure, if you're diabetic. This does change your potential risk with any type of surgery. So next we'll look at a normal appearing hip. This shows the anatomy of the hip. The hip is a ball and socket joint. The blue material you see there covering the ball is the cartilage, and that's the layer of the joint surface basically. And that's what is the smooth, slippery, gliding surface, and that is what eventually wears down with osteoarthritis. So typically, it's a ball and socket joint. You have a nice round spherical ball, but as time progresses with arthritic change, that can even change the shape of the socket and the ball as well. Here you see a picture of an arthritic hip. You can develop the bone spurs, the narrowing of the joint space related to the wearing down of that cartilage layer, the bone spurs, the cystic changes that you can see on an x-ray, and this is an x-ray, or this is an example of an arthritic hip as compared to normal. Next. So what's involved with replacing the hip? Essentially what we're doing is we're removing the arthritic areas. We remove the ball and we insert a metal stem that goes down into the thigh bone that has a either metallic or a ceramic ball attached to the top of it. And then we remount the socket or the cup, and we put in a metal liner that has a plastic insert. That recreates that smooth joint surface by either the metal on the plastic or the ceramic on plastic, or whatever bearing surface is inserted, recreates that smooth gliding articulation that allows for better motion of that joint, better function of that joint, and less pain. So now we'll change gears a little bit and we'll talk about knee arthritis. Arthritis of the knee is incredibly common. In 2010, so 10 years ago, there were 600,000 knee replacements done in this country. It's predicted that in 10 years from now, or in 2030, that number is going to rise to over 3.5 million, and that's related to the aging population as a whole. It is expected that almost half of Americans will develop arthritis in at least one of their knees throughout their life. So that just demonstrates how incredibly common it is, and it's probably the most common thing that most orthopedic surgeons see in the office. Next slide. So here you have an example of a normal knee. Okay. So the knee is the strongest and largest joint in your body. It's made up of the end of your thigh bone, called the femur, the top of your shin bone, called the tibia, and then your kneecap, also known as the patella. There are several supporting structures, such as ligaments on the inside and outside, as well as meniscus tissue, which also acts as a cushion and shock absorber and provides some additional stability. Next slide. So deciding on when to proceed with knee replacement surgery, very similar to the hip. It's when the pain gets to the point that your activity is declining and you're not able to be as independent. Once you've tried some of the non-operative measures, such as the medications, injections, therapy, perhaps bracing, or even use of a cane, if it persists and it's really limiting you, then it's when you should consider doing the knee replacement. Again, we're also looking for the radiographic signs or the x-ray findings that are supportive of that diagnosis. Next slide. This is just an example of some of the various types of knee replacements. They all have a similar basic concept where we're not removing the entire bone at the ends of the joint. What we're doing is essentially resurfacing. So we make a series of geometric cuts at the end of the thigh bone, and we insert a metal cap that goes on top of the end of the thigh bone, and that creates that portion of the joint. Then we insert a metal tray into the top of the shin bone, and in between there's a plastic liner, and that recreates that smooth gliding surface. There are multiple variations on this, including some that remove certain ligaments, others retain them, and the two on the right are a little bit more advanced. It's oftentimes used for severe deformities or bone loss, which has occurred as a result of either prolonged time or prior trauma, or for revision situations where an older knee replacement needs to be removed and a new one inserted. And that's where Dr. Kim comes in with his specialty training. Next slide. So this is a good example of an arthritic knee x-ray. On the left, you can see that they have a lot of the classic signs of arthritis on an x-ray. There's narrowing of the joint space, especially on the inside. There's some hardening of the bone and some bone spurs and perhaps even some cyst formation. And the image on the right illustrates a postoperative knee where you can see the metal cap that's been applied to the end of the thigh bone after making a series of cuts, the metal tray that sits in the top of the shin bone, and in between, that space that you see is the plastic that's there that's not visible on an x-ray. Also, when you're looking at the far right image, that's an x-ray of a postoperative total knee from the side view. And you can see on the back of the kneecap, there's a little metal ring there that some implants have, and that's where we place a plastic button on the back side of the kneecap, which glides in a groove at the end of the thigh bone. So overall, I hope this was an informational talk for you to give you a brief overview of what is arthritis, how do I manage it, and what are my options for managing it and dealing with it. When do I need a knee replacement? When do I need a hip replacement? And is it a good surgery? In my opinion, it's one of the most successful surgeries out there, both for the knees and for the hips, especially for the appropriate patient. So I think with that, we will try to answer some questions. So do we want to do live questions or? Okay. All right. So we have a couple questions that were submitted on Instagram from the joint seminar. One is from Mary. It says, I'm only 30 and have a horrible knee. It pops every time I bend it. I used to be able to go to the gym and now I can't because of the pain. Is there something that can be done to take care of this? I would say absolutely there can be something done to take care of this. Being of such a young age, I think it's doubtful that it's an arthritic problem. I think a reasonable place to start would be an x-ray, just to assess overall alignment of the joint, and if you do have any degenerative change. But there are other things that can cause knee pain, especially in younger patients who do not have arthritis. The most common would be something with the meniscus, such as a meniscus tear. So I think a reasonable place for you to start, Mary, would be to touch base with either your primary care provider or one of the orthopedic surgeons in town to at least get a baseline x-ray, a history, a physical exam, and then that would give us a better idea of which direction we need to go as far as coming to a definitive diagnosis. So, another question was from @Rosebud252. It said, you would like to know more about hand surgery. I think that's it's a little broad, but all of the orthopedic surgeons in town do take care of hand issues. It depends on, is it a traumatic disorder? Is it a chronic degenerative problem? So I think probably the best thing would also be to get in touch with either your primary care doctor for a baseline x-ray or with one of the local orthopedists. Okay. All right. So we had a question come in live. It says, when are knee surgeries resuming? From Maggie 2277. So we've already begun resuming elective surgeries like total knees, total hips, and other outpatient procedures. We're doing it gradually and safely. There are extra precautions taken. We still don't allow visitors inside the hospital to minimize exposure risk. But we are doing total knees and total hips already. Yeah. So we have a list of commonly asked questions as well, and I'll let Dr. Kim take a couple of these too. The first one is it the right time to undergo a knee replacement?
Yeah, so I think Dr. Mihalcin did a great job in talking about when it is the right time to undergo a joint replacement or knee replacement. And it's basically when you've tried all of these non-operative treatment measures. You know, we're surgeons, so we love to operate, we like to cut, but you know, before we get to surgery, we want to try everything that's non-operative, you know, like medications, like injections, physical therapy. And you've tried those things and you're just still in pain, you know, you just can't do the things that you want to do, and it's affecting your quality of life, then I think it's time to consider a joint replacement or a knee replacement.
So I view that question a little bit differently. When people say, is it the right time to undergo a knee replacement? Obviously, you know, with what's going on in the world now with coronavirus, I think that's a common question that we get too. And as I said, we are resuming those surgeries at this point slowly and safely. But I still think if you're hesitant, that's a personal choice that you would have to make on your own. It is an elective procedure, so if you're able to manage your symptoms appropriately, you don't have to have a joint replacement until it gets to the point where it's really limiting you. So the second question was, can I avoid surgery? And I think we've established absolutely you can to a certain point. You can manage the symptoms as best as possible with all of the non-operative treatments that we discussed, ranging from healthy weight, low impact exercise, medications, injections, physical therapy, perhaps a brace or an assistive device such as a cane or even a walker for balance and safety. So you can definitely avoid surgery, but arthritis at the same time is a progressive condition, so it will continue to get worse as time goes on. But at least in the short term, you can avoid it as long as you need to.
So another question is, what happens during surgery and how long does it take? So it all depends, you know, if it's a straightforward joint replacement, it could be anywhere from an hour, hour and a half. Certainly, there are cases where there's deformity or there's, flexion contracture, stiff knee, or they're post-traumatic. You've had a big accident before in the past, and now you're presenting with bone-on-bone arthritis. So there are certain situations where it could take a little bit longer. But basically, during surgery, again, for a knee replacement, again, it's very similar to like a knee resurfacing. We have, anesthesia that's involved. We typically use a spinal anesthetic for knee and hip replacements. And we have a big team they all work together. It's a coordinated effort, and we'll get you through safely.
Next one is what is an artificial knee and how does it stay in place? So the artificial knee is typically made out of a metallic alloy where you have a metal shell that fits onto the end of the thigh bone, a metal tray on the top of the shin bone, and a piece of very rigid plastic in between that has a very low wear rate. So it's better than ones that were designed years and years ago in that their longevity has been increased as a result. They stay in place through a number of different ways. They can be placed in what's called a pressed fit, where it's just pushed onto the bone and that tight interface allows it to stay in place. Oftentimes the knee replacements will have little pegs. You can add screws. You can add cement as well. A lot of that is dependent upon the design that is being used or the type of knee replacement that's being used, which is very surgeon dependent and really what the surgeon's preference is.
Should I worry about anesthesia? So again, like I mentioned, we typically prefer spinal anesthetic. It is a safer way to do operation. You have less blood loss. Your blood pressure is a bit lower during surgery. But if we cannot get a spinal anesthetic in, then we go to a general anesthetic. But even before you're brought to the OR, before even anesthesia is administered, we have you see your primary care doc. We have you see your cardiologist, just to make sure you're safe enough to undergo a major operation.
Okay, the next question is how much pain will I expect to have after surgery? That's a different question for everyone. Pain is expected. We try to minimize that pain through a variety of ways, including injections of local anesthetic towards the end of the surgery, or peripheral nerve blocks, which also can provide some pain relief that anesthesia can provide as well. We try to minimize the amount of narcotic use if possible, because those medications have their own subset of problems associated with them. But typically I'll tell people that for the first 2 or 3 weeks after a knee replacement or a hip replacement, they're going to wonder why they did it, and they're going to be questioning me. But after that, it really starts to turn the corner, and people feel great. And especially with the hip replacements, the way we do the hip replacements now have far less pain in the early post-operative period compared to other approaches. So a lot of times their pain is controlled well after surgery, where we'll let people go home the same day or typically the next morning.
We have a question here from Instagram. The question is, what would you suggest for her 95-year-old mother whose hip is bone-on-bone? So what I would say is, if you are considering surgery, if you've tried all of the measures, you've tried their Tylenol, you've tried the ibuprofen, you've tried the injections, and you're still having pain, and she's quite active, and the hip is bothering her, it's limiting her ability to do things, I think it's okay to consider a joint replacement. Again, we're going to have her see a primary care physician. If she has a cardiologist or a nephrologist, we'll have her see the specialist just to make sure, is she a candidate? Can she safely go through surgery? So we have a team here, and it's a coordinated decision. And it's not just, oh yeah, you need a hip replacement or a knee replacement. We make a coordinated effort to get her to the right decision.
Also, I think it's important to keep in mind that there's a difference between chronologic age and physiologic age. I've seen a lot of 95-year-olds who look like they're 70 and they're still very active. So as long as she's appropriate for surgery, I don't think age is necessarily the deciding factor. Next question is, what should I expect immediately following surgery? So when people have a hip or a knee replacement here at Quia Delta, once the surgery is completed, they go to the recovery room, and depending on whether they're going to be planning to go home that same day or spend the night, they may go up to the floor for a little while. They are typically gotten out of bed with the nursing staff as well as physical therapy as soon as possible. If they've had a spinal anesthetic, we have to wait for that to wear off so that they can start getting up and getting out of bed and moving around. You will expect to have pain, and pain medicine is provided if requested. We do try to minimize the narcotic use, so that's why we use multiple medications to try and attack the pain from a lot of different angles. Typically, the next morning, if you spent the night, as long as you're walking a reasonable distance safely with a walker, with physical therapy's assessment, and your pain is controlled just with the medication that you're going to be going home on, then we let you go home.
There is a question. Do you offer less invasive hip surgery where you may only make a small incision? You know, all the surgeons here at Cahuilla Delta, you know, we do offer the anterior hip replacement, which is a incision that is placed in the front of the hip. And typically our incisions are, you know, usually 10 centimeters or less, which is considered minimally invasive. So we do offer that. The classic approach is the posterior lateral approach. I mean, there are cases where we may need that if you have a big deformity. But you know, all of the surgeons here do a great job in doing the anterior hip replacement, which is considered minimally invasive.
I would say with both hip and knee replacement, we are as minimally invasive as possible. For a while, minimally invasive knees were very, very popular, but the problem is if you can't see well enough to do a good job, you're not saving the patient or doing them any good by making the incision an inch smaller. All incisions will heal from side to side, so a 2-inch incision will take the same amount of time to heal as a 12-inch incision. And I think most of us are of the thought that you're going to make whatever incision you need to do a good job, because that's the primary importance.
All right. There's another, what is the average post-op recovery time for a knee replacement? You know, I tell patients, you know, the first 2 weeks are extremely painful, you know, especially after a knee replacement. You'll be on a walker for a week or two, a cane for a week or two. But usually about a 6-week post-op mark, you're going to feel okay. You're going to be, I had surgery, I'm feeling a little bit better. But it's usually about a 3-month, 4-month mark is when you feel, okay, you know, I feel pretty happy with the decision that I made. But, you know, overall, I tell patients, you know, it may take up to a year where you feel like you're back to your normal self. You'll notice little increments of improvement over time over the course of the year, which you may not appreciate, but you will get better and better over time.
Okay, the next question says, I'm in need of having my knee replaced. According to my orthopedist, I teach, so I would like to plan the surgery to allow for recovery that matches the school year calendar. I think that's very reasonable. Again, this is an elective procedure, so it can be timed out to fit your lifestyle as well as your work schedule, and that's an incredibly common thing with the teachers. They all want to plan it out to either coincide with the end of the school year or even sometimes over Christmas break. But yeah, it's very reasonable to do that.
All right, we have a question from Kathy. Does avascular necrosis and collapse of the femoral head make a surgery more difficult / longer? Does waiting for surgery for avascular necrosis cause the surgery to be less successful? I would say that it can make it difficult if you wait too long. So if you have a large collapse and your leg becomes shorter and shorter, then during surgery we try to get it back out to length. So it might be more difficult if you wait too long. But I think overall you'll have a good outcome, certainly if your femoral head or your hip bone is collapsing.
And then the next question is, which doctors specialize in hip replacement, and how is it decided whether to go with a metal or ceramic hip replacement? So all of the doctors in town do hip replacements. We all do knee replacements. We all do sort of a general orthopedic practice, some with their specialty areas of interest. But the decision on whether to use a metallic ball or a ceramic ball a lot of times is based on two things. First, surgeon preference, but also the sizing. I think most of us probably do use a ceramic ball because it's a stiffer material. I think it does very well. Sometimes we will use the metallic ball if we can't get to a certain size, which may necessitate use of the metal ball. But I think for the most part, everybody in town is using ceramic with a plastic liner on the inside of the shell. There are other times where you would perhaps use a different liner inside the shell, such as ceramic, but that's pretty uncommon, usually reserved for a very young patient who has some disorder where they absolutely needed to have a hip replacement as one of their only options, because the ceramic on ceramic has a long wear characteristic. But for the most part, I think everybody uses the plastic liner on the inside of the metal shell with the ceramic head on top of the stem. There's
That's all
this
the
one.
questions.
Yeah, there's this one.
All right, yeah, there's a question, what can I expect during recovery and rehabilitation? I think all the doctors will agree that, hip replacement is a much easier recovery than a knee replacement. So in terms of a knee replacement, you'll be again using a walker for a week or two. It's going to be extremely important to get your knee out straight, but also to bend it back. So we'll be kind of looking at that, in our clinic visit and a post-op visit, just to make sure, are you getting your knee out straight? Are you bending your knee appropriately? It's going to be painful. You're going to be working with physical therapy. The physical therapist is going to push you. You might think like it was a bad decision early on, but overall, I think it's a successful operation. So just be mindful that it's going to be painful, but it will get better.
It is a partnership between your surgeon and you as the patient. So if we can do a great job on the surgery, but if you don't do your part to really put in the effort with the therapy, you won't do as well as somebody who does. The other thing I would also just bounce off of Dr. Kim is that, especially with knees, the physical therapy is really, really important. Knee replacement is not a motion restoring surgery. So going into it, if you have limitations of your motion, such as a flexion contracture where you can't get your knee all the way straight, you may get a few more degrees of motion with the knee replacement, but the soft tissues around the knee have contracted down and they have a memory. So even if we stretch them out, it's going to always want to go back to that original position. That's why physical therapy, especially after knee replacement, is really, really critical.
How can I prepare my home for recovery? One of the first things is to make sure you have somebody at home to help you in the first week or so, just in case. You'll be able to walk, get up, use a walker, but just in case you need assistance, we usually recommend you have some sort of help available, whether it be a friend or a family member that stays with you. We also make sure that you do have the right equipment at home, whether it be a walker, a raised toilet seat, just to make sure your risk of fall is minimized.
Next question relates to special equipment. Typically after a knee or hip replacement, you are going to be using a walker for several days to several weeks. After that, perhaps transitioning to a cane and eventually not using anything to help get around. Some people will inquire about something called a CPM, or a continuous passive motion machine. These were used previously on knee replacements where patients can lay in bed and they strap the leg into this device that slowly moves the knee and straightens the knee. Most of the studies have shown that really doesn't improve outcomes, but it definitely adds to cost. So as a group, the orthopedic surgeons in town, we come together and we kind of agree on best practices, and typically we do not use those for a primary joint replacement. Maybe if somebody is having a revision or if they had a stiff knee that needed manipulated, that would be used, but most people are not going to use the CPM because it also allows patients to be a little bit lazy. They tend to lay in bed and just let the machine do the work. If you get out there and get into the physical therapy and do the work, you'll have a better outcome, especially with the outpatient physical therapy, in my opinion.
What activities will I be able to engage in? You can pretty much do anything that you want to do. The only things that we don't really recommend is repetitive high-impact exercises, such as running a marathon. You probably could do it, but if you want your joint replacement to last a long time, then we would recommend trying to avoid those repetitive high-impact things. But you can certainly go out for hikes, go out for a short jog. You can play with your kids. You can go shoot basketball. And the other thing that I get a little nervous about as a surgeon is people that practice yoga and they get into very extreme positions of yoga after hip replacement. That makes me a little nervous. So I would probably recommend against doing extreme forms of yoga, but yoga is allowed as well as Pilates.
We have a couple more questions online. First is, how common is hip replacement dislocation after surgery? Fortunately, not very common. And with the anterior approach, which is what I believe most of us in town are doing, it's even less. Part of that is there are a lot of different things that can factor into the potential dislocation of a joint replacement, not just the approach, whether you do it from the front or from the back, but mostly it's the implantation of the components. So if the cup is positioned too far, rotated one way or the other, that can make it easier for a hip to dislocate. Anybody who had some pre-existing laxity of the musculature around that area without appropriate tension restored afterwards, maybe a little bit more loose in that joint even after the hip replacement, may allow it a little bit more easily to come out. But also putting yourself in certain positions can predispose you to having a dislocation of the hip. This is sometimes seen, especially with posterior approach hips, where they are going in further back through the butt cheek, essentially. And if you lean too far forward, say to tie your shoes, it can always pop that hip out the back. With the anterior approach, that isn't likely to happen unless the components are malpositioned, but purely from a surgical standpoint, you have a reduced chance of a dislocation with the anterior approach as compared to posterior. But I don't want to say it's impossible.
One of the other questions is how long will the artificial knee joint last? You know, the old data, the old plastic that was used, you know, several, tens years ago, they were shown to last at least 15 years. But we have much better material nowadays. We have what we call highly cross-linked polyethylene liner. We have better techniques. And so our hope is that the knee joint will last at least 30 years or more. But again, also depends on the patient activity levels. Again, if you're constantly pounding away, doing marathons in your knee replacement, it probably won't last as long. But we do hope that the knee replacement will last at least 30 years or longer.
Now the question is, how long is the hospital stay? This varies depending on the patient and what type of surgery. Typically the hips recover a little quicker in the early postoperative period to where hip replacements, if they're young, healthy, doing well after surgery, they go home the same day. So some of them are staying for a few hours after surgery and then eventually walk in with therapy and then they go home. I'd say most people spend the night and then go home the next morning. There are occasions if people are a little bit slower to mobilize and get moving that it might be a little bit longer.
Yeah. What is the limiting factor that would prevent one from getting joint replacement? I would say number one is, are you a healthy candidate for surgery? We want to make sure that you are first and foremost healthy so that you can undergo this surgery safely. So, we order preoperative lab work just to make sure, are your hemoglobin levels, are they appropriate? Do you have the appropriate platelet count? Do you have risk factors? Do you have a bleeding disorder? Is your diabetes under control? Is your weight, is it getting better? We typically, classically, look at BMI as a number, but, are you trending down to where you're making an effort to get your weight down? So we look at a whole host of factors to make sure that you're able to go for surgery safely.
So the next one I think pertains to revisions. I'm going to let Dr. Kim take that next one.
I know 3 people who have had to have hip replacements removed, the area healed for several months, and then have a new replacement put in. How frequently does something like this happen? It's kind of freaking me out. It sounds like if they had their hip replacement removed and let it heal, it sounds like it's probably an infection where they got an infection after a primary hip replacement. They had to take the hip replacement out. They put a temporary spacer in there where they have to get rid of the infection, get IV antibiotics, and once the antibiotics kick in, the infection is cleared, get tested again, and then go for a replantation. I would say infection occurs 1% or less. It's very rare that it happens. We give you antibiotics before incision. We give you antibiotics after incision, after surgery. Even during the operation, we use modalities like dilute betadine just to minimize our risk of infection. And we also make sure that you're safe beforehand, meaning your diabetes is under control. Is your kidney functioning well? Do you have, if you get a preoperative MRSA nasal swab, are you getting the appropriate antibiotics? So there's a lot of things that we check off first, but certainly can happen. But again, it's about 1% or less, but it's extremely rare for that to happen.
Do we have any other questions coming in online or? No? All right. All right. Thank you, everybody.
Thank you very
I believe
much.
that concludes.
Thank you, everyone, for joining us online at home. Like I said before, if now or at any point you're interested in talking to someone further offline about joint replacements, please use the chat feature in the call that we did today. Include your name and contact information, and someone will get back to you. You can also call 624-3804. And a big thank you to Dr. Mihalcin and Dr. Kim. Dr. Mihalcin works at Visalia Medical Clinic, and Dr. Kim works at Orthopedic Associates. Stay safe, everyone. Thank you.